I will talk to you about a program that we implemented to implement evidence-based practice guidelines for management of bronchiolitis. As you all know, hospitals are getting prepared to adopt the new healthcare reform. And one of the biggest challenges is to reduce waste, or what we say utilization or resource utilization. So developing evidence-based practice guidelines and implementing them was one of the methods we chose at Children's Medical Center Dallas. And today I will tell you sort of our story for last 2 years about how we did and how we impacted. So before I start, how many of you all are involved in management of children with bronchiolitis? Just with a show of hands. So a lot of you, looks like it's a very common condition then. So why bronchiolitis? Because we have high number of admissions every year. There is variability in practice within our institution, and we also found there is huge variability in practice when we compare ourselves to peer hospitals. There are no published quality indicators, although we all know that American Academy of Pediatrics published their guidelines in 2005. So this is a slide which shows peer hospital comparison. Children's Hospital Association is a network of 43 children's hospitals, and we usually benchmark ourselves to see how we do when compared to other hospitals. So if you look over there, Dallas is in red. We have the highest number of admissions. Now, I don't know whether we admit more or is it just we see sicker population. Our length of stay before we started our guidelines was 3.8 days. If you look at Cincinnati Children's Hospital, which we often look at benchmark because their outcomes are better, they have been doing this process 5 years before we started. Their length of stay was 3.1 days. The number of chest x-rays, American Academy of Pediatrics recommends there is no evidence to do chest x-rays. 70% of our patients get chest x-rays. If you look at Cincinnati Children's, 14% of their patients get chest x-ray. If you look at Fort Worth, our friendly neighbors, 75% of their patients get chest x-ray. So there is variation within ourselves. There is variation within the peer hospital comparison. Inhalation rate, the use of bronchodilators. We use 57%, Cincinnati is 15%, and Cook Children's is 9%. At the same time, Houston is 90%. That's the variation when there are standardized guidelines. Antibiotic rate, we use 50%. At Cincinnati, the odds of somebody getting antibiotics is 11%. If you are at Fort Worth, 50%, Houston, 57%, and if you are in CHOP, you're 28%. So that just tells us the amount of variation that is there in healthcare despite standardized practice. So why evidence-based practice guidelines? There is evidence to suggest that evidence-based practice guidelines can streamline care, they can reduce length of stay, they can reduce utilization, and they can reduce cost of care. So our goal was to develop evidence and consensus-based guidelines for management of children with bronchiolitis. How did we do this? We did this in 3 phases. It started in 2010 and implemented first season in 2011 and first season in 2012, and second was this last season that just passed over. We did this in 3 phases. The first one was selection phase, the second was development phase, and the third one was an implementation phase. In the selection phase, we pulled a bunch of stakeholders and formed a bronchiolitis task force. Who were our stakeholders? Stakeholders were physicians, nurses, pharmacists, respiratory care, physicians from emergency room, community pediatricians, inpatient, emergency, ICU, pulmonologists, infectious disease specialists. We reviewed our current practice. We reviewed the national and other institutional guidelines because there was no point starting from scratch when so much work is already done. So we built on what was done. We developed questions about where there was variation, and then we looked at scientific evidence, reviewed literature, and we developed a grading strategy. As we all know, we all have our own behavior and practices, and it takes time to change. And when you go to a bunch of physicians with a practice change, you better have the evidence. So we felt it is important. I cannot tell you don't do X-ray. I need to show you evidence because we are talking to educated people who've learned medicine through scientific methodology. So we followed a very rigorous methodology, and we developed our clinical practice guidelines with 11 recommendations. We identified key measurable quality markers. There is no metric to say who is doing well in bronchiolitis, which physician or which practice or which hospital. There are no markers. So we picked up our own markers to see what could be a best way to define that we are going in the right direction. And we incorporated all these into our EPIC order sets. Now there's more and more evidence, and most of you probably are already in electronic medical health records. As we have got used to electronic health records, now we are pushing ourselves further to make them automated, use decision support, make our lives easier. And when we develop guidelines, I have residents asking, so how many clicks do we have to do? And now there's pressure to do as less clicks as you can do, but get all the orders in. So you can see how pathetic we get day by day, but I guess that's the way we are going. So the next was implementation phase. It's one thing to develop a guideline, it's another to implement. And the biggest example of that, I would say, is American Academy of Pediatric Guidelines. In 2005, the guidelines were released. 6 years from now, you saw the outcomes. So there is no point just bringing a piece of paper and putting it on the website. We really have to go to providers and get their buy-in and find ways to make, cause organizational change, cause physician change, and also involve the healthcare organization administrators to help us develop certain metrics, find cost-effective ways to do things, and find personnel who can help us in implementation and following these order sets and following these metrics. So with that, we developed our guidelines. Wherever evidence was lacking, we developed consensus statements. For example, when should you refer a patient to emergency room? What should be our admission criteria? How do you escalate care on the floor? Who should go to ICU? Who should get discharged? There was no criteria along these lines. It all depended on who the attending physician was. So this is a copy of how our guidelines look. We have a short version of 2-page for quick read for busy people. We have a long version, which is almost 20-page document. We also streamlined bulb suctioning technique. For many of you who've been to our centers, there is this culture of deep suction. And if you were, during September to April, if you were on a floor, you can hear that suction. And everybody was running around doing deep suction. There is no evidence for deep suction. And however, there is very strong evidence that good nasal suction can help pulmonary toilet. So we streamlined bulb suction techniques. We developed a video to educate everybody. So everybody uses a standard technique to suction the kids. And this was a huge learning experience for me because I did not know when you suction through a bulb, you don't open the bulb out. You let it inflate on its own. And that pressure is enough to cause a good suction. So we developed these in English and Spanish. This is a video. We had a video on a baby and a toddler about how a mother can hold a baby and a toddler and do a good suction. We develop pathway or algorithm, and this is a common terminology which is coming. To develop pathways about from start to end what to do, and yes, no, and different branches, and when you get stuck, how you go about. And we develop a website. As one of the studies which I was doing with CHA Hospital, we found that having an easy, accessible guideline is the most important step in reducing outcomes. So it's very important for providers 24/7 at 2 o'clock in the morning, if there's a discussion whether you should start oxygen or not, and there's a discussion based on our guidelines, they should be easily available. So we developed a website, and on the website we have put all our guidelines. As you can see, we have appendicitis, asthma, bronchiolitis, we have pneumonia, septic shock, and skin and subcutaneous infection coming in the next year. So providers can go to the website and get all the information needed about the guidelines. These are available on children's intranet. The video is available as well as education material if any of you all want to see or would like to get a video or a copy of it. So I'll touch briefly on what the guidelines were. Inclusion criteria, as you know, all the evidence is for healthy kids. We do see a lot of kids with complex medical condition, but there is no evidence for those, so we stuck to the evidence, and the guidelines recommend only for healthy kids less than 2 years of age. These guidelines may be applicable to children with high-risk condition at physician discretion. So we left that open. Definition, as you all know, it's an acute viral illness, most commonly in children less than 2 years old with lower respiratory tract infection of presumed viral etiology. Diagnosis of bronchiolitis is clinical. We at an academic institution are also training our residents and students, and it's very important to get the right practice from the beginning. It's a clinical diagnosis. There is no test, there is no X-ray finding, there is no lab that can diagnose bronchiolitis. So a good clinical judgment is what diagnoses bronchiolitis based on history and physical. What is recommended? Lab tests, CBC, SED rate, CRP, blood cultures, urine cultures, CSF studies are not recommended in management of healthy children with bronchiolitis. Chest X-ray, not recommended in healthy children with bronchiolitis unless you are suspecting pneumonia. In that case, your diagnosis is pneumonia, not bronchiolitis. The other question which always comes up is what about those little babies, 3 months old, where they come with fever? There is incidence of serious bacterial infection in children with bronchiolitis. However, it is very low, less than 2%. So in the peak of a season, if you have a child who comes with classical features of bronchiolitis, the chances of that kid having sepsis is less than 2%. Admission criteria. We did not have any formal admission criteria. You could be admitted depending on who the attending was. And one of the big factors was oxygen. There were some kids getting admitted at 95%, 94, 90, 80, 89. There is clear recommendation from AAP of 90%. So we streamlined our care and said the admission criteria would be persistent saturation less than 90% requiring oxygen. And this became the criteria even on the floor to wean the patient off oxygen at 90%, not 95, not 98, not 97. We also streamlined about what is respiratory distress, when do you admit a kid for observed apnea, and further escalation of care. Monitoring. This was a big factor in the inpatient medicine. Often patient gets admitted, they are put on monitors, and as you would expect Murphy's Law, monitors alarm at 2 o'clock in the morning, they get put on oxygen, they end up staying extra. So we developed very clear guidelines on who do you monitor and how do you monitor. Again, there is evidence. There is clear evidence from the AAP that spot pulse oximetry is what is required on kids who are not on oxygen. And even if you want to put a kid on continuous pulse oximeter, the reason you typically put them is there's a risk of apnea in very young kids for the first 24 hours. After that, there is no need to monitor these kids on continuous pulse oximeter. Sometimes, just to say that we've got so used to over-monitoring, and this was one of the very important factors which helped us reduce our length of stay. What about the bronchial hygiene measure? Position and posture is important. Nasal suction is the preferred way of providing nasal clearance. Deep suction is not recommended. This was one practice I would say when I implemented the guidelines, and I worked very closely with the nurses, and they were like, Dr. Mittal, we buy into everything except deep suction. And if you don't deep suction kids, kids will drown. This was the common cultural practice. And we reduced deep suction by the numbers I'll show you, and believe me, nobody drowned. It was just a practice. Chest physiotherapy, not recommended. Nasal decongestant, because we used to deep suction so much, we used to use a lot of neosynephrine. I would say, I think the stock of neosynephrine went up from Children's Medical Center in the winter season. And because we stopped doing deep suction, we hardly ever use neosynephrine now, and nasal saline drops are enough. Medication, this was another practice, and I have two of my chief residents sitting at the back. You could smell a bronchiolitis patient, you could hear a bronchiolitis patient because they were always on nebulizers. We were giving them albuterol, Zopinex, epinephrine, you name it. Now, there is some evidence that they may have some value. So what about that kid who comes with wheezing? Maybe it's an asthmatic, maybe the kid has hay fever, strong family history of asthma. So the recommendation is a single trial may be considered, but only if eczema, atopy, or family history of asthma. We developed bronchiolitis score, which are well validated, not as well tested in many centers, but they are reasonably well validated. And we put in our system where a patient, if a provider wants to use a bronchodilator, you score them, you give the bronchodilator, and you score them again. If the score went down by 3, that means it's a response, and you can continue. However, if there was no change in the score, there was no need to continue that bronchodilator. So the similar for epinephrine. Steroids, there is no evidence for use of steroids in children, healthy children with bronchiolitis. There is definite evidence of affecting causing delayed school learning problems with steroids in early age. And we clearly, we persuaded physicians to consider not using steroids. Antibiotics, unless there's a specific diagnosis, unless you have a diagnosis of UTI or a pneumonia, it is not recommended. And we emphasize that ear infections are overdiagnosed. And in fact, as a hospitalist, I've stopped looking at the ears because most of the patients I get from the ER have already got a dose of Rocephin. So it is in our practice, and we all know we overtreat ear infections. Decongestant antihistaminics, not recommended. Again, over-the-counter cough, cold medication, which we don't use very often in our practice, but there's no evidence to use them in the bronchiolitis as well. Suction, as I told you, even suction for the people who really found it very hard to give up deep suction, we said, well, try it yourself, believe in what you do, and then you stop your practice if you feel comfortable with it. So we said, use the score, suction the patient, and if the score changes after deep suction, feel free to continue, otherwise do not. And this we incorporated in our EPIC order sets. This was the bronchiolitis scores that we used. We developed criteria for escalation on the floor about when to transfer to the ICU. We developed ICU transfer criteria, in fact, even communication criteria, when to communicate, when to escalate care, just to streamline care. We developed discharge criteria, and one of the most important factor here was oxygen, because that affected length of stay based on who the attending physician was. We emphasized on what is respiratory distress, about feeding orally as far as possible, as far as tolerated, and then teaching every parent about bulb suction use through videos and education materials. We developed outcome metrics. Our main metrics were chest X-ray. We knew we were around 70%. We thought we'll try it and aim at 25 for the next 3 to 4 years. Let's see how we do. We said up to 2 bronchodilators are allowed. So anybody more than 2, hopefully that will come down if people are scoring correctly and reducing utilization. Antibiotic was 50%. We said let's try less than 25%. Our length of stay was 3.8 days. We just very arbitrarily said, let's just see if we can go down to 2.8 days. Chest physiotherapy, we were very ambitious. We said it should be 0% because healthy kids should not get chest physiotherapy. Readmission rate, codes, spot pulse oximeter use, we wanted to increase. We were monitoring way more than we needed to, and we said, let's see if we can bring the culture of spot pulse oximeter use, and if we can go even up to 50% from 0%. Cardiorespiratory monitor, we wanted to reduce, and deep suction, we felt very strongly that has to go away from our culture. So the next thing was implementation. As I said, it's one thing to develop a guideline. The guideline will not go anywhere if you don't have key stakeholder buy-in. So for buy-in, we educated all the providers. We educated all the nurses, respiratory therapists, acute, the APNs, residents, attending physicians. This was done through a checks module. This was done through direct education, through grand rounds, through our department presentation, through resident noon conferences. We developed order sets in Epic, and we made them as click-friendly, the word these days is as click-friendly as possible. And we had, in the order set, we had a box which says this patient is to be used in evidence-based practice guidelines, which was used as a communication tool, so a nurse knew that this one is a believer, so it's okay to start oxygen only at 90, it is okay not to deep suction. So it was a communication, whereas if a provider didn't want to believe, they didn't have to tick the line. In that case, the nurse would ask them, when do you think I should start oxygen? When do you think I should give albuterol? So it was sort of a communication used in the order set. And then we started tracking our metrics. Couple of things that we use as a strategy to get buy-in was sharing of our metric. It was always very transparent. We maintained the transparency. Every month, we started sending metrics to division directors to share with their faculty about how they were doing. Often when you implement these kind of guidelines, there is a lot of chaos, there's a lot of change, because you change a practice, you change our behavior, we all get uncomfortable with the change. So how did we do with our guidelines? So all this time, I've been showing you data from the FIS database, which is how we use for comparison. I will now show you data from our own Children's Medical Center EPIC outcomes data. So the numbers may look a little different from what I've shown you, but I wanted you to look at the comparative numbers. So this is the volume. At Children's, we see about 1,200 patients every year, and it went down to 1,159 after season 1, which was 2011 and 2012. And I actually have season 2 data for the season that just finished in 2012, 2013. I'll show you that as well. Our length of stay was 2.42 days in EPIC. It went down to 1.79 days, which was reasonably significant. Our readmission rate did not change. So it's not that we were discharging patients early and they all came back. It was not significant. Our chest X-ray rate reduced from almost 60% to 45%. Doesn't look a lot, but if you compare the p-values, there is a significant reduction. Inhalation rate more than 2 doses. Now this I feel very, this is one metric which is not used by many centers, and I feel you will start seeing this coming up, because this seems to be a very good metric which allows provider to try albuterol epi. And from 21%, we went down to 14%, which was again significant. Our antibiotic rate did not change much. So we still are using a lot of antibiotic. It was 38%, and we are still at 35%. But for the start, in the first year, we thought this was a reasonable metric, because we didn't expect anything to move in the first year. There is strong evidence to suggest that once you develop evidence and practice-based guidelines and implement it, it takes over 10 years to see any change. So in that 1 year, we felt this was a reasonable thing. And the next thing which we did for the season was we said, how else can we entice physicians to start using our guidelines? So we applied for American Board of Pediatric Maintenance of Certification for Part 4, and we got that. And this season, we started telling providers, if you as a practice can reduce the metric, we will start giving you more credits. And this was with the division directors and Dr. Zeller's office that we are working with. So if you look at this graph, this is for length of stay. And initially when we started, the average was, let's see if I can, 2.42. And this is us being little ambitious and saying, let's try to keep it at 2.5, which was the initial one. After the first season, this is the 2 days. We went down all throughout. And these are monthly plots that we do and we share with the providers. This year we achieved mock certification, and this is last season. So from 2.42 days, we went to 1.83, although the previous season we were 1.79. Chest X-ray utilization, we were 59%. We went down to 45, and we are down to 39%. This is all data from the ER and floor altogether. We are aiming 25%, but remember there are no national metrics. Nobody knows what's the number to stop at a child with bronchiolitis and say, in your practice, 25% is okay. We don't know if we will ever reach 25%. But once we do for 3-4 years, and if the number stabilize, maybe that's the metric we should all aim for. Antibiotic utilization, from 32% to 30% to 27%. So not a lot, but at least some downward trend. So looks a little optimistic that maybe we'll start reducing as time goes by. Bronchodilator use, this is one of the metrics where we feel we have succeeded the most because no other centers have been able to reduce bronchodilator use as much, and this has been an ongoing challenge. We started with 27%. Again, this is not total number of bronchodilator. I think that is way higher. This is more than 2 doses only. So 27% of our patients used to get bronchodilators, and now it went down to 20% last year, and this season our bronchodilator use was 14%. And in talking to the nurses, they really feel that yes, they are not running around as much doing nebulizers. They do feel they have more time, and that time is spent more in education than running and doing deep suction or bronchodilator. How did we do in the emergency room? This is just a slide which I wanted to show you. We did not implement an emergency room in the first year. It was only implemented on the floors. In the second season, we implemented in the emergency room. But this is just to tell you how physician behaviors change. We educated everybody, but we officially did not change. But even without implementing and knowing that there are guidelines and the metrics are being tracked, the length of stay in the emergency room reduced from 176 minutes to 149 minutes, and it was significant. Chest X-ray utilization reduced from 33% to 25%, which was all good, moving in the right direction, which is where we are all moving with the APR, DRGs, and the bundled care coming, trying to reduce the waste. How did emergency room do with chest X-ray this year? And I think this was a beautiful slide to see. They were at 60% only emergency room, 45% before guidelines were implemented, and this year they went down to 21. So some buy-in, some change in culture that yes, we are doing X-rays way more than we should be, and the numbers are coming down beautifully. How did we do in the ICU? There is no evidence for any management in ICU. But again, knowing that there are guidelines, knowing that there is cultural change, knowing that evidence is being pushed, physicians' behaviors change. And our length of stay went down in ICU from 7.4 days to 5.93 days. I don't know how this changed because our case mix hasn't changed, our volumes haven't changed. Maybe it is the oxygen, maybe it is a deep suction, maybe it's the bronchodilator use. We don't know, but all we know is our length of stay has reduced. And as you all know, these have cost implications. With bundled care, with APR, DRG, we are all going to be getting one single payment for each condition. So reducing that length of stay and utilization has huge implication for every hospital and every practice. This is just a slide to show deep suction. We performed 12-13 before guideline implementation and 44 after guideline implementation. And last season, the numbers were so low that we stopped tracking this metric. Chest physiotherapy dropped from 12.25. It was not a big thing in our system for Healthy Kid. It dropped to 6.1%. We have stopped tracking this metric. What next? We have gone ahead, and this year we implemented these guidelines in ED. We reinforced inpatient physicians, showing them this data and showing them how beautiful they had done to see if we can all together push the metric a little bit further and see. Because we don't have the number, we just try and see how things go. We also have developed an algorithm for outpatient physicians, which we didn't roll out as much as we would like to. Maybe the next season we will. We also had contacted Dallas Physician Society and emailed our bronchiolitis guidelines. So this is all I have to present. I'm happy to share any questions, or if you all want any materials, we'll be happy to provide you with that. So if you all have any questions, I'm happy to share. This is our task force, which involved not only physicians, but nurses, respiratory therapists, IT physicians, and many other people.